When we're talking about eligibility criteria, we're talking about documenting these things in a way that if an auditor looks at them, they are going to understand that the patient is homebound, agree that the patient can't leave the home unattended, and things like that. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about home health Medicare eligibility. But first, if you like our content, please like, share, and subscribe. So, what is home health Medicare eligibility besides a mouthful? Home health Medicare eligibility talks about kind of the criteria you need to hit to be able to admit and bill a home health patient. I think I've mentioned in a different video before that there's like participation in the Medicare program rules, and then there's billing rules. So eligibility criteria falls into the billing rules bucket. Essentially, to be able to participate in the Medicare program, there's some certain set of compliance requirements. And then to bill and receive payment for a patient, there's a different set of additional requirements for that. Eligibility criteria for both home health and hospice fall under the billing bucket. If you're not billing a patient, you still have to be compliant to the original participation rules, but not to the billing rules. So for example, if you're just enrolling into the Medicare program, you don't have to necessarily mind the eligibility criteria concepts that way. Of course, you should practice, but you don't have to. Once you start billing as a company, every single patient you bill Medicare needs to be compliant to these criteria requirements. And so let's jump into what the eligibility rules are. First and foremost, for home health, homebound status is one of the most important criterias. And one more kind of little general detail about this. The home health eligibility criteria, there's a couple of things, and they're very vague. So it's very subjective, which is, I guess, good for auditors. But let's jump into it. So homebound status is one of them. Homebound status means that the patient has a hard time leaving the house. Long story short. Pretty much, they shouldn't be able to leave the home by themselves. If they're able to safely leave home by themselves and go anywhere, that means that they're probably not eligible for your home health services. I'll give you some examples. If the patient can leave their home, walk to their car, drive somewhere, and go somewhere, they are not homebound. Homebound means that they can't do that without the assistance of somebody else. The whole point of having a homebound requirement for home health services is that if the patient is not homebound, they should be seeking this treatment somewhere else. At the doctor's office, at a physical therapy clinic, whatever the appropriate setting is for whatever it is they're doing. If they aren't able to leave the home by themselves, that is why we are sending clinicians to their home, because they can't go and get the treatment somewhere else. And so homebound status is like number one requirement for home health patients. But what does homebound status mean? Of course, we can say, oh yeah, they don't leave the home or they can't leave the home, right? But when we're talking about eligibility criteria, we're talking about documenting these things in a way that if an auditor looks at them, they are going to understand that the patient is homebound, agree that the patient can't leave the home unattended, and things like that. Later, we'll go into how to document a little bit around these things. But really, what we're talking about is somebody can't really leave home by themselves. If they do, it's extremely difficult for them. Like, for example, maybe this patient can somehow get to their car, right, from their front door, whatever, but they have to stop like 6 times, catch their breath, they get dizzy in the middle. So when we're saying homebound or they can't leave unattended or whatever, we're not saying that they're like stuck in their bed and like literally cannot leave no matter what. We're saying that it's not safe for them to do so. Yeah, maybe they can like crawl over to the car and like climb in. Yeah, okay, sure. But like if they're at risk for falls definitely as they leave the home and things like that. Now we're getting into homebound status. Usually patients who are homebound, they're not leaving every single day to go to like leisurely places all day long. That's not to say that they're not people that they're by law confined to the home or anything like that. Of course, they can go anywhere they want, whenever they want, whether it's safe or not for them to do so. I mean, of course, that would be against your medical advice, but they're free people and can do whatever they want. But that does mean that when they go, typically patients who are homebound, they're not like every single day going somewhere. So when they leave, they're probably going to a doctor's appointment, maybe for some religious outing or something, you know, some church or whatever, things like that. Maybe to some family event, but it's not like every single day they went to Starbucks. Now they went to like the supermarket for a leisurely stroll. So this is not the behavior of a homebound patient. There are very specific ways to document homebound status. And if you're documenting on an oasis, most oases do a good job of capturing like kind of how to describe homebound status and things like that. But you want to make sure that the patient remains homebound throughout the entire treatment. The next eligibility criteria is medical necessity. Another really vague kind of, this one's a super vague concept. And honestly, like, I feel like I personally am a little frustrated with how vague these things are. And I understand why they're vague. Like, people are individuals. And so any individual human, yeah, we all kind of like live the same lives and go through the same things. And, you know, the human condition is going to have generally like a lot of the same themes. But as an individual, you have a, you know, unique set of genes, a unique set of like disease expression. Someone might have like diabetes and hypertension. Someone might have heart disease and something, whatever, you know. So my point is that I understand that Medicare, you know, when setting these requirements, they can't come up with every nuanced, detailed example of what this could mean, because it could just be a variety of things or a combination of things. So I get why they're vague, but they're just like, they're so vague sometimes. And so the idea is that medical necessity means that the patient needs the healthcare they're receiving. Good luck with that one. So, okay, we can rule out a couple of things from there, right? You're not providing unnecessary medical treatment. So, I mean, you guys are probably much more clinical professionals than I am. So I'm going to give a stupid example, but you can create a much more educated example for yourselves that you can do. But like, it's like giving like, I don't know, it's like doing wound care on someone without a wound, right? Like if they don't need it, you don't need to do it. And so that's part of medical necessity. But really what we're talking about is that the care that's being provided is necessary for the rehabilitation and the goals that you're setting. And the goals are necessary to improve the patient's condition, blah, blah, blah. But there's nothing specific in this. So some things that describe medical necessity is if you have to do an actual hands-on treatment, this is going to really help your case. Typically in home health, you're going to have two kinds of care. And that, I mean, that's probably all of healthcare. One is hands-on treatment, wound, IV, injection, I don't know, things like that. The next one, physical therapy, like hands-on, we're doing something. The other one is teaching. Teaching is critical. It's very important because like, okay, let's say, imagine you're a person, right? You go to the doctor's office and they're like, congratulations, now you have 5 diseases. Here's like 15 meds you have to take. Morning, middle day, this one with food, this one before sleep. Don't take this one on an empty stomach, blah, 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 blah. Like, ugh. Like I'm personally, when I get sick with the flu or something, like I'm having a hard time, like how to take my Tylenols, you know, things like that. Like it's like hard to remember that stuff. So I can't even imagine being like, geriatric, maybe like reduced like memory or whatever. Then on top of that, here's like 53 meds. Here's a pharmacy of meds to keep track of. So teaching is very important to make sure that the patient is taking their medications appropriately. Of course, if you're not taking medications appropriately, this could come with a whole slew of side effects and all the way up to death. You know, it's just, so I'm not trying to knock teachings. Teachings are very important. But teachings is where you really get into, is this medically necessary? Is this not medically necessary? territory because, okay, if you've admitted a patient for an episode, okay, chances are you'll get that episode paid. If they meet eligibility criteria. However, if you're now recertifying and all you're doing is teaching, even if they remain homebound, it's like you're gonna have a hard time justifying that stuff over time, you know? So anyways, have fun with that one. It's medical necessity, it's vague, it's tricky. The best thing you can do for these two things is go and read the local coverage determinations on how these things get approved or not approved by auditors. This is the best thing you can do to understand how to properly document this stuff and what cases are deemed medically necessary versus homebound versus not. Like if a patient is homebound just because they're lazy, I mean, I'm not trying to be not cool about things, but sometimes people just, like, I'm 41 and I'm almost homebound because I don't want to go anywhere, you know. So that's not homebound, right? So you have to like clinically justify this stuff. Anyways, one quick thing about medical necessity is in home health, you have something called qualifying discipline. And so there are certain disciplines and certain treatments you can give on their own or whatever with others. And there are certain things that you can't do unless you have one of these qualifying disciplines. So like nursing is a qualifying discipline, physical therapy is a qualifying discipline, and so on. We can do a separate video on these nuances. But long story short, you can't admit a patient for just home health aide or just social worker. You can provide those things while another discipline is also doing something. But like if every skilled discipline is discharged and you just have home health aide now, like you can't have home health aide and nothing else. So these are some kind of concept of medical necessity also to keep track of, that like, for example, you can't just admit someone for home health aide and keep them going. Or let's say like nursing, you had nursing and home health aide, 4 weeks in nursing is done, but you continue for the rest of the episode for the home health aide. Like your medical necessity ended when the nursing care ended. So there's like details like this. It's worth getting super, super familiar with all of these little nuances in homebound status and medical necessity. But it's like these two things are like a big puzzle, right? And like we've been given like 15% of the pieces. And the rest of them are like, they belong to another puzzle. So you got to kind of like figure out which pieces fit, and you know 15% of what's going to fit for sure. So do your best with that. Next, there's some rules. While this isn't, okay, this is eligibility criteria in that it needs to be part of the picture, but it's not like obviously like the patient falls into this category or not. But the patient needs to be under the care of a physician. So somebody needs to be directing this care, because in home health, we do not have a doctor on staff. And so every patient's random doctor is like the boss of that home health episode. And so you can't have a patient if there's no physician managing the care, because we, as home health agencies, we are a company of nursing, therapy, kind of like all of the important clinical staff that's not the doctor that's directing the care. And so the patient needs to have a doctor that is managing their care. That doctor must refer the patient and be okay to sign the care plan and manage the care plan. So this is important. If you get when this comes up is, let's say, you know, grandma's friend wants home health. Grandma's friend doesn't have a doctor. I mean, it's really hard to find a geriatric person without a doctor, probably, but anyways, it happens. So if you're like new to the industry, just if any kind of like, oh, I found patients at the church, bingo night, or, you know, wherever it is you go to look for patients, just like question number one is, do you have a doctor that can refer home health? If not, this is a really good time to kind of like talk to your medical director, whatever, things like that, right? Next, pretty much this doctor whoever it is needs to be okay following with the patient. And part of this also is that the patient needs to visit the doctor. Sometimes if a patient doesn't have a doctor, it's just a lot of times it's because they're like not going to a doctor, right? And so they need to actually go to the doctor to get a home health referral that will be accepted at billing. Because the other kind of part of physician stuff in home health eligibility criteria is the face-to-face encounter. This is I mean, all of these are critical, obviously, like without any of them, even one of them, you're not going to get paid. But the face-to-face encounter is going to be a pass-fail in a lot of cases. If you don't have a qualifying face-to-face encounter, they're just going to throw the whole chart away. Like no review needed. So the face-to-face encounter goes like this. Pretty much the patient sees the doctor face-to-face. That's why it's called a face-to-face encounter. They can't just refer on a prescription pad on a phone call or something. Telehealth has made this interesting, but we're not going to go into those nuances. Just straight up, what is a face-to-face? They see the doctor in their doctor's office or whatever, face-to-face, for the problem in which home health services are being referred. If they are seeing the doctor for like a headache, and then the doctor was referring for foot pain, like, I'm not clinical, I'm not giving good examples, but you get what I'm saying. Like, the visit for which you are using that you will get the face-to-face encounter from the doctor for needs to be related to the issue that they're referring to the home health. That's one. 2, timing. That face-to-face needs to happen within 90 days prior to your home health referral or 30 days after. So you have 100, this is not a hard requirement. You have 120 days. They're 90 before, 30 after to figure this thing out. But they need to be for the same reason. And the doctor needs to write a narrative as to why they saw this patient in the office, they're attesting to this. They saw the patient in the office, the patient came for this reason, this is why I'm referring home health. There's a specific form for this. So like, the form can look this way. It's not like a NOMNC, notice of Medicare non-coverage where it's like, use this exact paper. It's not like that. They can use different forms. They can use your software form. I don't know, whatever. But the point is there are specific kind of elements to the form. So just make sure you're using the right elements. So those are kind of like the 4 really what's defined as home health eligibility criteria. Without that face-to-face, like literally they'll just throw the whole chart away. And the doctor also bills that visit. So like they can actually catch that through their automated billing system and then deny your claim without a review just for lack of face-to-face. So like, careful with that one. But I want you to really consider the 5th unspoken eligibility criteria of every single thing in healthcare is you can have a perfect patient, perfect home health patient candidate. Like straight up homebound, bedbound, straight up, needs the service. You got the face-to-face. If you are not justifying homebound status on every single note throughout the entire episode, you are very in danger of not being paid for the claim. And so back to the common saying, if it wasn't documented, it wasn't done. You need to justify this so hard, like literally, like just kill everyone with the justifications. If you're not describing that patient's condition like in an intense, crazy, redundant, you have to describe it to the point where you're sick of describing it, like this. So that if a reviewer ever gets their hands on this chart, they are like, yes, this is homebound. Yes, it has to be like an obvious yes, like this. Because you could have the most eligible patient, and if you're not documenting properly, that's it. Like, documentation is like, in terms of ADR stuff and billing, getting paid and things like that, documentation is 80% of it. Because you could do 100% of perfect treatment, and if your notes aren't right, like you're getting denied for the whole chart, and they don't care that you guys did the best healthcare treatment on earth, So you really want to document this properly. How do we document this properly? Every single note, every visit that is turned in needs to justify homebound status and medical necessity, like no matter what. So if you are hiring a QA or a reviewer or whatever, even at the entry level, job number one is the patient's name. Remember elementary school is your name on it? Patient name, clinician title, date, all these things. And the literal next thing, then of course, vitals, blah, blah, blah. Literal next thing, homebound status, medical necessity. Like, no matter what. You want to describe this via checkboxes and via narrative. When we talk about describing it via narrative, what we are talking about is like you turn on your creative writing at that point. Describe that patient as if you're writing a novel. Like literally, I entered the door, the house, the patient was seated in their armchair, like whatever, like this level of description. Alert, oriented, they had this much energy, I don't know, whatever. Just do your best in describing why we are doing this. First of all, if there's ever any like, did they come do this visit, this kind of dispute, your description of like where they were literally sitting in their house and things like that is just going to add to your justification. That's one. But secondly, the description could be the difference of somebody like visualizing medical necessity or visualizing homebound status. And by the way, this is how surveyors do it. Like if you get a surveyor from the California Health Department Plan of Corrections, every deficiency starts with, like if there's a home visit, every deficiency starts with how they found the patient. The patient, like literally how I described, it's like a romance novel. The patient was seated, they were tired, they were this, they were that. Like the full emotional state of the patient is described. They will spend like 10 sentences of the total deficiency description, like 4 of them will be describing the patient, or like 3 of them. So you want to mimic that. It also helps people understand and put context to the like factors in all this stuff. Like for example, I might be homebound, but I can walk 20 feet. You might not be homebound and you can only walk 10. How? Because maybe the distance between my front door and my car is 50 feet. And the distance between your front door and your car is nothing. It's in your garage. You just need to get down to the garage. So like at that point, maybe both of us can sit in the car and just drive fine. You know, it's getting there. You might be able to walk 50 feet, but might not be able to navigate stairs at all. And there might be stairs on the way to your car. Okay, now you're homebound. Congratulations. Like my point is describing this in narrative helps people understand why this guy's homebound but can walk like 15 feet. This guy's not homebound but can, you know, whatever, all these like specific, because sometimes you see documentation, they're like, can't leave home, and it's check mark, right? Like these are usually multiple choice things on a form. So they check all the check boxes. Can't leave home as assisted, taxing effort, whatever they are. And then the physical therapist like working on walking 35 feet, you know, like 35 feet, like I can go to my supermarket in 30, whatever. So the point is describe the narrative so people understand why they're homebound given their circumstances. And medical necessity, same thing. Someone could be totally physically fine and then just like cognitively severely impaired. So you really have to like paint that picture in a serious way. Of course, this is obvious. If you're going to bill Medicare, you need to be Medicare certified. And that's pretty much it. These are kind of like the details of home health eligibility criteria. It's homebound status, medical necessity, must be under the care of a physician, and face-to-face requirement. All right. Why does this matter? Because if you get into ADR problems, you're not going to get dinged on homebound medical necessity stuff at a survey. They're not looking for that stuff. I'm not saying that you shouldn't be like documenting for survey or whatever, but like that's not what they're looking for. If you ever get into an ADR situation and you don't have homebound status and medical necessity down, right? You're going to get denials. Even if you did perfect treatment. That's why this is important, and it's important to get right. I want you guys from now on, anytime you have a surveyor in your office, to use them as an educational resource, not it's the government, I'm scared. Every time you have a surveyor in your office, Just ask them to death about how to document homebound status medical necessity to the best of their knowledge. Surveyors typically will come from other places. They have seen a wide variety of like documentation, this and that, and they'll give you a really good idea of best practices. They are the best consultants out there for clinical documentation. When you have a surveyor in your office, do not waste the opportunity. Really ask them about this homebound status medical necessity and how to document it properly to pass ADR. Long story short, good luck with everything. This was home health eligibility criteria. I hope you guys really get this down and get paid on all your ADRs, because ADR prep starts at admission. And again, I'm Mariam Treystman from the Home Health Consultant. If you like our content, please like, share, and subscribe. Thank you.